Acute ischemic stroke. I mean, it is one of the most immediate, one of the most dangerous threats to human health.
Absolutely. When a major artery that's supplying the brain just suddenly plugs up the tissue downstream, it starts dying almost instantly.
And until pretty recently, our options were, well, they were limited. But over the last decade or so, we've seen one of the biggest clinical breakthroughs in memory.
We're talking about mechanical thrombectomy, or MT. For the first time, we have a superior treatment that can genuinely restore blood flow in many of these, large vessel occlusions.
Right, these landmark trials you hear about Dawn and Diffuse-3, they didn't just establish MT as the gold standard.
No, they completely changed the game. They radically expanded the treatment window, sometimes up to 24 hours from when the patient was last known to be well.
That expansion is just massive.
Mm-hmm.
But it introduces a whole new complex phase in stroke care.
For sure.
Once the team has navigated up into the brain and physically pulled out that clot, the work is, well, it's far from over. The moments and the hours after that procedure, they require intense, meticulous monitoring. The clinical team has to know if a patient is having an expected, a mostly benign side effect or a dangerous, potentially catastrophic complication.
And this all comes down to imaging. Our mission today is to unpack the source material used by neuroradiologists and neurointerventionalists. These are the experts guiding the procedure and then watching for the aftermath.
Okay.
We need to see how they evaluate success, spot the benign things that look like a disaster, and crucially, identify the life-threatening red flags, whether they're in the brain or, anywhere along the path the instruments took to get there.
Okay, let's unpack this. What exactly are doctors looking for once the clot is gone?
So first, a really quick recap on eligibility. The
Yeah.
core criteria from those big trials are, 1, no evidence of a pre-existing hemorrhage.
No bleed to start with.
Exactly. 2, they have to present within that 24-hour window. And 3, they have to have a targetable large vessel occlusion. We're talking about the major highway arteries, like the internal carotid or the M1 segment of the middle cerebral arteries.
And the tools they use to get that clot out have gotten incredibly sophisticated. The source material breaks down a few main techniques.
Yes. There's aspiration MT. It's often called 8APT. It's basically a large catheter that acts like a powerful mini vacuum cleaner, just sucking the clot out.
Okay.
Then you have the stent retriever-mediated MT. This uses a self-expanding wire mesh. Think of it like a tiny, intricate fishing net.
It just grabs the clot.
It captures the clot and pulls it back out. And very often, they'll combine these techniques. Sometimes they even use flow arrest to prevent any little fragments from breaking off and floating downstream.
So the goal of this whole thing is to restore flow. But the sources are really clear that there's a difference between recanalization and reperfusion. Help us with that.
That is a fundamental distinction, and it gets confused all the time. Recanalization is simple. It's just vessel patency.
You open the pipe.
You open the pipe, the clot's gone, the vessel is open again. But reperfusion, that is the goal. That means you've successfully restored normal flow to the entire brain territory that vessel was supposed to supply.
Ah, so recanalization is just opening the front door, but reperfusion is making sure the entire house gets heated.
That's a perfect analogy. And reperfusion is what really translates into the functional recovery that we all want to see for the patient.
And to measure that success, they use a standardized report card, the TISI score.
Exactly. The expanded thrombolysis in cerebral infarction score, or TISI, is the standardized metric. When the team reports a TISI score, they're telling everyone how much of that territory got flow back.
And why is that so important?
Well, we obsess over this score because higher scores correlate directly with better clinical outcomes, specifically something called the modified Rankin score, which is just a measure of how well the patient is functioning 3 months later.
So if TISI 0 is a total failure, no reperfusion, what's the magic number they're aiming for?
TISI 3 is the ideal, complete reperfusion. But TISI 2B and 2C are considered highly successful. When you see TISI 2B, that means over half of the territory received flow. TISI 2C is almost complete, maybe 90 to 99%.
So that's the goal.
The goal is always to get to TISI 2B or better. That's the threshold where you really start seeing significant functional gains for the patient.
Okay, so the TISI score is assigned, and then the follow-up imaging begins almost right away. Why is that needed, even if the procedure seemed to go well?
3 main reasons. First, you have to evaluate the success. Did the clot stay gone? Second, you want to determine the underlying cause of the stroke to guide long-term prevention.
Right.
And third, and this is the most critical part, you have to rule out any hemorrhage before you can start secondary prevention therapies like antiplatelets. You just cannot give blood thinners if there's an active expanding bleed in the brain.
And that initial check relies heavily on the non-contrast CT. It's fast, it's everywhere, and it's good at spotting big problems. But the source material highlights this massive diagnostic challenge here.
The challenge is the great mimic. We're trying to tell the difference between something totally benign that just looks like blood and a dangerous complication that is blood.
And what are those two things?
Extravasated contrast material, the dye from the procedure, and acute blood products. Both of them appear bright white or hyperattenuating on a standard CT. If you can't tell them apart, you might hesitate to start those life-saving antiplatelets.
This is where we need a superpower. What's fascinating here is the technology used to distinguish contrast from blood. Dual energy CT, or DECT. Explain how that works, maybe without getting too deep in the physics.
Okay, so think of DECT as giving the radiologist a pair of special glasses. A regular CT shoots X-rays at one energy level. DCT shoots them at two different energy levels at the same time. And it turns out that iodine, which is in the contrast dye, and hemoglobin, which is in blood, they absorb these two energy levels differently.
Ah, so the computer can spot that difference.
Exactly. The computer exploits that. It can generate what's called an iodine subtraction map, which effectively says, okay, computer, ignore everything that behaves like iodine dye.
And when you remove the dye, what's left behind is the truth.
Precisely. The iodine subtraction map just removes that bright contrast staining, leaving behind only the actual underlying blood products. It gives the physician certainty in a really high-stakes, time-sensitive situation.
But if DCT isn't available, MRI is still the most sensitive workhorse.
Absolutely. Diffusion-weighted imaging, or DWI, that's critical for assessing the final infarct size, how much brain tissue actually died. And for spotting blood, susceptibility-weighted imaging, or SWI, is incredibly sensitive. It really outperforms a standard CT in differentiating those subtle blood products from contrast. You also mentioned diagnosing the underlying cause for future prevention. The sources bring up a newer technique, vessel wall imaging, that goes beyond just looking at the flow.
This is a deep dive, literally. Instead of just looking at the vessel lumen, the inside of the pipe vessel wall, imaging visualizes the arterial wall itself.
So you can see the health of the artery.
Yeah, it lets us assess underlying issues like plaque from atherosclerosis or expected changes from the MT procedure itself, like a little thickening where the stent was deployed. It gives us clues about why that clot formed in the first place.
Let's shift gears to the good news, or at least the expected news. What are some of the findings that might look alarming but are actually benign after an MT?
Well, first, the goal, recanalization. If the flow isn't a perfect T-psi-3, we look for any residual clot. That just means the plumbing isn't fully clear yet. It shows up as a filling defect on a CTA or an artifact on an MRI.
But the finding that really seems to throw the most fear into the clinical team is contrast material staining. Why does the contrast leak out, and how long does it stick around? So this phenomenon is tied directly to the stroke itself. Normally, you have the blood-brain barrier. It acts like a fortress wall, right? It's very restrictive about what it lets pass from the blood into the brain tissue.
Okay.
But during an acute stroke, that lack of oxygen, the ischemia, it causes inflammation, and it damages that fortress wall. It makes the barrier much more permeable.
So when they inject the iodine dye during the MT, it just leaks right through those new holes into the damaged brain tissue.
Precisely. This extravasated contrast material stains the surrounding tissue, and it appears bright on the CT, mimicking a small hemorrhage.
And it doesn't go away quickly.
No, because that tissue is damaged, it can take up to 48 hours for the body to slowly clear that dye. And that delay is just unacceptable. If the team has to wait 2 days to confirm if that spot is benign dye or dangerous blood, they are delaying critical, life-altering secondary prevention therapy.
Which is why a tool like DCT is so important.
Exactly. It resolves that uncertainty in minutes.
Another flow-related finding is hyperperfusion. You reopen the dam and now the water is rushing through.
That's the effect. We see increased blood flow to that revascularized territory. It shows up clearly on CT perfusion studies as high cerebral blood volume. Right now, the literature is a bit unclear on whether this is a good or a bad thing.
Really?
Yeah, some studies suggest it's linked to an improved prognosis, while others link it to potentially poor outcomes. What it really signals is that the vessel is highly active, and it absolutely warrants close monitoring to make sure that rush of blood doesn't become a problem.
Okay. Here's where it gets really interesting and critical for patient outcomes. Let's talk about the disasters. What happens when things go wrong inside the brain? We can look at ischemic problems and hemorrhagic problems.
So on the ischemic side, the vessel can simply close up again, early reocclusion. It happens in a minority of patients, maybe up to 7% within 24 hours. The main risk factors are having really severe underlying
A
atherosclerosis.
really gunked up artery.
Right. Or if the physician had to make multiple passes to get the clot out, which can irritate the vessel wall.
And what about distal embolization? We hear about the clot fragmenting.
That happens in up to 8% of cases. Little fragments can break off during the MT and cause new, smaller strokes downstream. We also have to watch for unintended embolization. Sometimes tiny microemboli from plaque can travel to totally unrelated territories.
You see those on an MRI.
Yeah, we spot these as new little white spots on a diffusion-weighted MRI confirming a new small stroke event.
Now, moving to the hemorrhagic complications. The most catastrophic, truly terrifying event that the source material mentions is vessel perforation.
Vessel perforation is the complication every interventionalist fears. It's mercifully rare. We're talking 0.6%, maybe 4.9% of cases, but it carries extremely high morbidity and mortality.
And the risk factors are similar.
Yes, multiple passes or targeting smaller, more delicate distal vessels. When it happens, it results in a rapid large hematoma bleeding outside the brain and just a rapid and dangerous mass effect.
We also hear about vasospasm and then bleeding into the fluid space around the brain.
Right. Vasospasm is a transient narrowing of the vessel. It happens in 4% to 23% of patients, usually just due to irritation from the catheters. Most are transient.
And the other thing? SAH.
Small volume subarachnoid hemorrhage, or SAH, is actually common. Up to 36% of patients get a little bit of it, often near the intervention site, and it's usually benign. But a large diffuse SAH, that is a massive red flag that requires an immediate neurosurgical consult.
But the most common type of bleeding complication is hemorrhagic transformation, which is bleeding within the infarcted tissue. This is where that ECAS classification system comes in, and it really dictates the immediate decision.
This is the single most important distinction in post-MT imaging, and it all hinges on one simple concept.
Okay, what is it?
Mass effect. The ECAS system divides it into categories, but clinically the team is just asking one question. Is this bleeding causing a shift or a bulge?
Tell us about that critical distinction.
First, we have petechial hemorrhage, often called HI or hemorrhagic infarction. These are just small spots of blood, little speckles within the dead tissue, and crucially, they have no mass effect.
They don't push the brain around.
Exactly. And because of that, the presence of these small spots generally does not delay the start of antiplatelet secondary prevention. They're sort of expected.
But the other category is the game changer.
The parenchymal hematoma, or PH, this is large volume bleeding. It has mass effect. It causes things like midline shift, where the brain is pushed over, or it squishes the fluid spaces.
And that's bad.
It's very bad. PH is associated with worse functional outcomes, and it absolutely means you have to hold off on the antiplatelet therapy. This is the line in the sand.
So if you see a big bleed, the first question is it causing a shift? Because that determines whether you can start that preventative medication or not.
That's the entire clinical pivot. Substantial mass effect, whether from edema or a hematoma, risks cerebral herniation, which can be fatal. The team has to watch these patients with serial scans, comparing the latest images to the first ones to spot any expansion.
And in the worst case scenario,
the patient may need a neurosurgical intervention, like a decompressive hemicraniectomy, which is where they remove a section of the skull to relieve that pressure.
We've talked so much about the brain, but the source material reminds us that the risk doesn't start or end at the skull. Instruments traveled a long way to get there. Let's look at the extracranial complications.
We have to remember that. Complications can pop up anywhere along the instrumentation path, starting right where we gain access, usually the groin or the wrist. And these access routes have significant trade-off.
The femoral artery in the groin, that's the traditional route, right?
It is. It's the historical standard because it can accommodate the larger devices MT requires, but it does carry a higher bleeding risk. Groin hematomas are pretty common, 5% to 23% of cases, but they're usually manageable.
But there's a scarier one.
The truly terrifying one is the retroperitoneal hematoma. Mercifully rare, less than 1%, but it's a major bleeding emergency.
Radial artery access through the wrist is getting more common. Why is that?
Well, radial access is non-inferior for getting the job done, and it has a statistically lower major bleeding risk. The trade-offs are that the procedure can take longer, and the wrist artery is smaller, which limits the size of the catheters you can use.
Any specific complications there?
The most common one is radial artery occlusion, which affects up to 10% of patients, though serious problems in the hand from that are rare.
And the last resort, direct cervical carotid access.
Yeah, that's usually reserved for patients with incredibly tortuous or diseased vessels. It carries the highest risk of local complications. A neck hematoma can develop in up to 8% of patients, and critically, 7% of those cases need an intervention, sometimes immediate surgery, because that hematoma can compromise the airway.
And what about damage to the big arteries in the neck themselves as the devices travel through?
Iatrogenic dissection, a tear in the vessel lining, is reported in up to 4% of cases. It's actually more common in these extracranial neck vessels than inside the brain, usually caused by the physical maneuvering of the devices. These injuries need close management, sometimes even a stent to stabilize the flow if the tear is large.
So what does this all mean? I mean, mechanical thrombectomy is truly a revolutionary procedure, expanding the window of opportunity for stroke patients everywhere.
It is. But that immediate success is so heavily dependent on the clinical team's ability to interpret these complex post-procedure images correctly.
Distinguishing the expected, like that benign contrast staining that just looks like a bleed from the genuinely dangerous, like a parenchymal hematoma that's creating mass effect, is the paramount task.
And the ability of the team to leverage advanced tools like DECT or MRI gives them the clarity they need. It lets them make these crucial immediate decisions about whether to start those life-altering secondary prevention drugs.
Which directly impacts the patient's long-term recovery.
Exactly. The imaging is the bridge between the procedure and the patient's future.
The sources do highlight some ongoing research into targeting smaller, more distal vessels, like the M2, M3, and P3 segments. These are deeper in the brain, supplying these really critical, eloquent areas.
Right. And while the current trials haven't shown a significant overall difference in outcome for these medium vessel occlusions compared to just medical management, the tension remains.
Does the potential benefit of saving that one vital piece of the brain outweigh the acknowledged higher risk of complications, like vessel perforation, that come with operating on those smaller, more delicate structures?
That is the cutting edge of stroke care. It is the question the neurointerventional community continues to wrestle with every single day.